Good evening, everyone. My name is Dr. Julian Yazigi. I'm a first-year resident in neurosurgery, and today I'll be presenting on spinal cord anatomy and physiology. So to begin, I'll be listing today's objectives. First is to understand the gross anatomy of the spinal cord and go over it, as well as the functional anatomy and physiology of the spinal cord. We will briefly talk about the reflex arc, and within each slide or top objectives mentioned prior, I'll be explaining the clinical and surgical significance. So to start off, the spinal cord forms the caudal continuation of the central nervous system, extending from its junction with the medulla oblongata at the foramen magnum to its tapered termination at the conus medullaris. Usually, this is at the level of the L1 vertebral body in adults and L3 in children. Although it appears as a single slender column of neural tissue, the spinal cord is a highly organized, segmentally arranged structure that integrates sensory input, generates motor output, and houses essential autonomic circuits. So, over here I have a little bit of regional anatomy. All right. The spinal cord lies within the protective bony confines of the vertebral canal, suspended in a complex anatomical environment designed to preserve its functions, cushion it from mechanical injury, and support the passage of neural and vascular structures. Although it is continuous with the medulla oblongata at the level of the foramen magnum, the spinal cord itself is shorter than the vertebral column, terminating near the lower border of the L1 vertebral body in adults, where it tapers into the conus medullaris. So below this point, the remaining of the lumbar and sacral nerve roots descend vertically within the subarachnoid space, forming the cauda equina. The mismatch in lengths between the cord and the vertebral column is a hallmark of human development, reflecting the faster postnatal growth of the vertebral column. So surrounding the spinal cord are three meningeal layers: the dura mater, the arachnoid mater, and the pia mater, which create distinct anatomical compartments. The dura mater forms a tough fibrous tube that encloses the cord and the proximal portions of the spinal nerves. Unlike the cranial dura, it's not fused to the surrounding bone. Instead, it's separated from the vertebral canal by the epidural space, which is a fat-filled compartment containing internal vertebral venous plexus. The space serves as a protective buffer, and is clinically significant as the site of epidural anesthesia and potential epidural hematoma formation. Deep to the dura lies the arachnoid mater, a delicate avascular membrane that closely lines the dural sac. Between the arachnoid mater and the pia mater is the subarachnoid space, which contains the cerebrospinal fluid and the vascular network that nourishes the cord. This space enlarges inferior to the conus medullaris, forming the lumbar cistern, a clinically important site for lumbar puncture, where CSF sampling can safely occur due to the absence of cord tissue. The pia mater, the innermost meningeal layer, adheres intimately to the surface of the spinal cord and sends out lateral tooth-like extensions called dentate ligaments. These ligaments anchor the cord to the dura mater at regular intervals, maintaining central alignment within the vertebral canal and limiting lateral displacement. The spinal cord is also regionally associated with the vertebrae, which form a segmented skeletal framework from cervical to sacral levels. Each spinal cord segment gives rise to a pair of spinal nerves that exit the vertebral column through the intervertebral foramina. In the cervical region, the cord is relatively thick due to the neural input and output required to supply the upper limbs, the cervical enlargement. This enlargement corresponds closely with the brachial plexus. The thoracic region is slimmer, reflecting the lesser motor requirements of the trunk and intercostal musculature. Inferiorly, the lumbar enlargement provides the neural circuitry for the lower limbs in association with the lumbar plexus. The relationship between the spinal cord and the vertebra changes progressively along the spinal axis. In the upper cervical levels, spinal nerves exit almost horizontally, closely aligned with their respective vertebrae. And as one descends, the increasing distance between spinal cord segment and corresponding vertebra produces more oblique nerve root trajectories. This is most pronounced in the lumbar and sacral regions, where long and fairly coursing roots form the cauda equina. Posterior to the cord are the laminae and spinous processes of the vertebrae, forming a bony roof, whereas anteriorly lie the vertebral bodies and intervertebral discs. The posterior longitudinal ligament lines the posterior surface of the vertebral bodies and intervertebral discs, while the ligamentum flavum connects adjacent laminae posteriorly. These ligaments maintain structural integrity and help to form the vertebral canal. Any compromise of these structures, such as disc herniation anteriorly or ligamentum flavum hypertrophy posteriorly, can narrow the canal and compress the cord or exiting nerves. The region around the spinal cord is further enriched with vascular structures. The anterior and posterior spinal arteries run longitudinally along the cord, reinforced by the segmental medullary arteries entering through the intervertebral foramina with the nerve roots. Venous drainage occurs through the valvulus plexiform network within the epidural space, which communicates freely with intracranial and pelvic veins, facilitating both physiological venous return and the pathological spread of metastatic disease. Clinically, the anatomy surrounding the spinal cord is essential for understanding trauma, degenerative disease, surgical approaches, anesthetic procedures, and tumoral spread. The close packing of neural, meningeal, skeletal, and vascular structures means that even small pathological changes, such as a disc protrusion, epidural bleed, or synovial cyst, can have profound neurological consequences. Conversely, the presence of the lumbar cistern and the separation between the meningeal layers creates a safe anatomical corridor for access to the central nervous system. So here I go into a little bit more detail with regards to the segments of the spinal cord. So it's organized into a series of longitudinal segments that reflect the embryological origins, right? The cord is divided into 31 spinal cord segments, each giving rise to a pair of spinal nerves. These segments are classified as 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal, mirroring the distribution of vertebral column despite the cord being significantly shorter than the spine. Each spinal cord segment corresponds to a portion of the cord from which dorsal or sensory and ventral or motor roots emerge. These roots merge to form mixed spinal nerves, that exit the vertebral column through the intervertebral foramina. While this arrangement is straightforward in the cervical region, where the segments align relatively close with their corresponding vertebral levels, it becomes progressively mismatched as one descends the spinal axis. In the cervical region, the spinal cord is characteristically enlarged, as I would have mentioned before, due to this cervical enlargement, which is around segments C4 to T1, due to the dense concentration of neuron pools needed to supply the upper limbs through the brachial plexus. Cervical segments lie approximately opposite their corresponding vertebrae, though C6 represents an anatomical exception. There are 7 cervical vertebrae, but 8 cervical spinal nerves, with C6 emerging below the C7 vertebra, while C1 to C7 are above their corresponding cervical vertebrae. Moving into the thoracic region, the spinal cord narrows. The thoracic segments primarily supply the intercostal muscles and thoracic wall via segmental nerves, resulting in a region that is less neurologically complex compared with the cervical and lumbar enlargement. Here, the vertebral segment mismatch becomes more pronounced. Mid-thoracic cord segments lie opposite vertebrae several levels higher. This region is also notable for its relatively poor vascular reinforcement, making it more vulnerable to ischemia, especially between T4 and T8. Inferiorly, the cord expands again to the lumbar enlargement, which accommodates the neuronal circuitry required to supply the lower limbs through the lumbar and lumbosacral plexuses. The enlargement is generally described to be from segments L1 through S3, but at the level of T9 to T12 vertebrae. The lumbar cord segments themselves are located opposite the lower thoracic vertebrae, well above the lumbar spine due to this mismatch. As a result, the spinal roots destined to exit the lumbar and sacral foramina must descend obliquely through the vertebral canal, forming the elongated bundle known as the cauda equina. Beneath the lumbar segments lie the sacral and coccygeal segments. They're compact and tightly clustered within the lower thoracic and upper lumbar vertebral levels. These segments give rise to nerve roots that supply the pelvic organs, perineum, and lower limb musculature. Because the spinal cord terminates at the conus medullaris near level L1, L2, all sacral and coccygeal nerve roots descend vertically within the enlarged lumbar cistern before exiting at their respective foramina. This anatomical arrangement is clinically significant, as I would have mentioned before, as it permits lumbar puncture below the level of L2 without risk of direct spinal cord injury. Each spinal cord segment is functionally associated with a dermatome, a myotome, and as we would have learned in previous classes in embryology, its own sclerotome, reflecting the pattern distribution of somatic sensory input, motor input, and embryological mesodermal derivatives. This segmental organization underlies many clinical examination strategies, allowing the level of a spinal cord injury or radiculopathy to be precisely localized based on deficits in cutaneous sensation, muscle strength, or reflexes. Here I'll discuss a little bit about the spinal nerve roots. So spinal nerve roots represent the critical interface between the central nervous system and the peripheral nervous system. They emerge from the spinal cord in a highly organized segmental pattern, carrying motor, sensory, and autonomic information to and from the body. Although collectively referred to as spinal nerves, each nerve initially begins as two distinct sets of roots, a dorsal or posterior root and a ventral or anterior root, each with its own embryological origin, structural features, and functional role. The dorsal roots contain the central processes of primary sensory neurons whose cell bodies are housed in the dorsal root ganglia. These neurons are pseudo-unipolar, sending a peripheral process to the skin, muscles, joints, or viscera, and the central process into the spinal cord. The dorsal root is therefore purely afferent in nature. As it approaches the spinal cord, it divides into multiple fine filaments known as dorsal rootlets, which enter the dorsolateral sulcus across several small entry points. Once inside the dorsal horn, these afferent fibers synapse across various rexid laminae, depending on their sensory modality. Nociceptive fibers entering superficial laminae, proprioceptive fibers projecting more deeply, and mechanoreceptive fibers ascending to form long tracts, such as the dorsal columns. On the other hand, the ventral roots contain the axons of the motor neurons located within the anterior horn of the spinal cord. These large alpha motor neurons, which innervate extrafusal muscle fibers, and gamma motor neurons, which regulate the sensitivity of muscle spindles. Ventral roots also carry the axons of sympathetic preganglionic neurons originating in the lateral horn of the thoracic and upper lumbar segments, as well as parasympathetic preganglionic fibers from the sacral segments. Because the ventral roots carry outflow from both somatic and autonomic systems, they're purely efferent structures. After emerging from the cord, dorsal and ventral rootlets converge into larger dorsal and ventral roots. These then unite with the within the intervertebral foramen to form a mixed spinal nerve, which carries both afferent and efferent fibers. This union marks the first point in the spinal pathway where a nerve contains both sensory and motor components. Immediately after formation, each spinal nerve will divide into a dorsal ramus and a ventral ramus, which further distribute to the body's musculature and skin. Importantly, the dorsal root ganglion remains proximal to the junction, serving as a sensitive clinical landmark. The morphological characteristics of spinal roots vary by region. In the cervical region, for example, nerve roots exit almost horizontally and relatively close to their corresponding segments, while in the thoracic they curse slightly downwards. Surrounding each spinal root is a sheath derived from the meninges. As the roots exit the dural sac, the dura mater extends laterally to form a dural sleeve, which transitions into the epineurium of the peripheral nerve. The arachnoid mater adheres to the inner surface of this sleeve, and CSF may extend a short distance along the root. The pia mater invests the root themselves supporting their vascular supply. This anatomical continuity explains why inflammatory processes such as meningitis can cause radiculitis and why root compression can impair both sensory and motor function simultaneously once the nerve becomes mixed. All right, so we're going to discuss the blood supply and perfusion to the spinal cord, starting with the arterial blood supply. We have longitudinal arteries which run vertically along the cords and contain one anterior spinal artery and two posterior spinal arteries, all of which originate from the vertebrobasilar circulation. The anterior spinal artery is formed by the union of small branches from each vertebral artery near the level of the foramen magnum. It descends into the midline along the anterior surface of the cord, lying within the anterior median fissure. This single artery supplies the anterior two-thirds of the spinal cord, including the anterior horns, cortex-spinal tracts, spinothalamic tracts, and most of the central gray matter. Because of its extensive territory, the ASA is critical for motor function and pain temperature sensation. The posterior spinal arteries, usually paired, arise either directly from the vertebral arteries or from the posterior inferior cerebellar arteries. They descend along the posterolateral sulci of the cord and providing arterial supply to the posterior one-third of the cord, including the dorsal columns responsible for fine touch, vibration, and proprioception. Their distribution is more segmental and variable than that of the ASA, and their territory is generally less metabolically demanding compared with the anterior region. These longitudinal arteries are not alone in the arterial blood supply to the spine and are joined by the segmental and radicular contributions. Because the longitudinal arteries can't sustain the entire length of the cord, they receive reinforcement from around 31 pairs of segmental arteries. These arise from different parent vessels depending on the region. Vertebral and deep cervical arteries in the cervical region, posterior intercostal arteries in the thoracic region and lumbar, and sacral arteries in the lower segments. Not all segmental arteries supply the cord directly, with many terminating in the paraspinal musculature, while a subset enters the vertebral canal through the intervertebral foramina as radicular arteries. These may further divide into anterior and posterior radicular arteries, which accompany the ventral and dorsal nerve roots, respectively. Even more important than radicular arteries are the segmental medullary arteries, a smaller number of larger caliber vessels that actually reach and augment the longitudinal spinal arteries. They provide the major reinforcements that maintain spinal cord perfusion, particularly in regions distant from the vertebral artery origin. The most clinically significant of the segmental medullary arteries is the artery of Adam-Kydridge, also called the great anterior segmental medullary artery. It typically arises between T9 and L2, most commonly on the left side, and this provides powerful vessels. This powerful vessel joins the anterior spinal artery and provides the dominant blood supply to the lumbar enlargement and lower thoracic spinal cord. Because it perfuses the anterior two-thirds of the cord at crucial levels, any disruption, such as during thoracoabdominal aortic aneurysm repair, in trauma or embolic events, can result in anterior spinal artery syndrome, which is characterized by bilateral motor paralysis and loss of pain and temperature below the lesion, with preservation of dorsal column modalities. Accompanying arteries, there will always be venous drainage, so the venous system, in this case, mirrors the arterial layout. A network of anterior and posterior spinal veins drains into the internal vertebral venous plexus, located in the epidural space. This plexus communicates freely with the cranial dural sinuses and the pelvic venous plexus. Because these veins lack valves, they serve as a low resistance pathway for metastases, particularly prostate and breast carcinoma, to reach the vertebral column and spinal cord via Batson's plexus. Physiological considerations to take in place is that in spinal cord perfusion, There is a dependency on the gradient between systemic arterial pressure and intrathecal pressure. Any elevation in intracranial or spinal canal pressure, such as from trauma, epidural hematoma, or severe hydrocephalus, can diminish effective perfusion pressure. The ASA territory is particularly sensitive to hypoperfusion due to its relatively limited collateralization compared with the posterior system. This vulnerability explains why global hypotension, such as during massive hemorrhage and prolonged cross-clamping of the aorta, may selectively injure anterior horn cells and corticospinal tracts. So now that we've understood and heard a little bit about the gross anatomy, let's discuss functional anatomy and physiology of the spinal cord. On cross-section, the spinal cord reveals a central core of gray matter shaped like a butterfly or the letter H, surrounded by white matter. The gray matter contains neuronal cell bodies and dendrites, interneurons, and synaptic networks. It's divided into dorsal horns, which receive sensory input, ventral horns, which house the motor neurons, and in the thoracic and upper lumbar levels, lateral horns that contain sympathetic preganglionic neurons. The organization of the gray matter is further refined by Rexed laminae, a system of cytoarchitectonic layers that reflect the functional specialization of sensory processing, motor integration, and autonomic control. The surrounding white matter consists of myelinated ascending and descending tracts. Ascending tracts include the dorsal columns, such as the fasciculus gracilis and fasciculus cuneatus, which carry fine touch, vibration, and conscious proprioception. The spinothalamic tracts, responsible for transmitting pain, temperature, and crude touch, and the spinocerebellar pathways, which convey unconscious proprioception to the cerebellum. Descending tracts include the corticospinal tracts for voluntary movement, along with extrapyramidal pathways such as the rubrospinal, reticulospinal, vestibulospinal, and tectospinal tracts, which coordinate posture, tone, and involuntary motor adjustments. The arrangement of these tracts is somatotopically precise, ensuring that fibers serving different body regions are predictably localized. Furthermore, the internal architecture of the cord, particularly the arrangement of gray and white matter, varies segmentally in accordance with functional demands. Cervical and lumbar segments contain large ventral horns due to the excessive motor neuron pool supplying the limb muscles, whereas thoracic segments exhibit a prominent lateral horn housing sympathetic preganglionic neurons. White matter is greatest in the cervical region, where ascending and descending tracts are present, and progressively diminishes towards the conus medullaris as more fibers synapse or terminate at higher levels. In terms of the spinal cord white matter, the long tracts of the spinal cord form the major communication highways between the peripheral nervous system and the brain. They're organized into ascending tracts, which carry sensory information towards higher centers, and descending tracts. Ascending pathways convey sensory information from receptors in the skin, muscles, joints, and viscera to the brainstem, thalamus, and ultimately the cerebral cortex. The most prominent system is the dorsal column medial lemniscal pathway, which occupies the posterior funiculus. This pathway carries both fine touch, vibration, and conscious proprioception. It's divided into the fasciculus gracilis, positioned medially and carrying information from the lower limbs and the trunk below level T6, and the fasciculus cuneatus, located laterally and conveying similar modalities from the upper limbs and the upper trunk. These fibers ascend ipsilaterally and remain uncrossed until they reach the medulla, where they synapse in their respective nuclei and decussate as the internal arcuate fibers to form the medial lemniscus. The second major ascending system is the anterolateral system, dominated by the spinothalamic tracts. The lateral spinothalamic tract carries pain and temperature sensations, while the anterior or ventral spinothalamic tract conveys crude touch and pressure. Unlike the dorsal columns, these fibers decussate within the spinal cord, usually 1 or 2 levels above their entry point, through Lasser's tract. Once crossed, they ascend contralaterally towards the thalamus. This organizational difference is clinically important, as lesions affecting the dorsal columns cause ipsilateral loss of vibration and proprioception, whereas lesions affecting the spinothalamic fibers produce contralateral deficits in pain and temperature. In addition to these conscious pathways, the spinal cord contains ascending tracts that transmit unconscious proprioceptive information to the cerebellum. These include the dorsal or posterior spinocerebellar tract, which carries information from muscle spindles and Golgi tendon organs of the lower limbs and trunk, and the ventral or anterior spinocerebellar tract, which conveys more complex interneuronal signals related to ongoing motor activity. Upper limb proprioceptive information is carried by the cuneocerebellar tract, which originates from the accessory cuneate nucleus. These cerebellar pathways allow for real-time coordination of movement and posture without conscious perception. In terms of the descending tracts, the pathways originate from cortical and brainstem motor centers and modulate voluntary movement, posture, tone, and reflex activity. The most significant of these is the corticospinal system, responsible for fine voluntary motor control. The lateral corticospinal tract arises from the precentral gyrus and decussates in the pyramids of the medulla, and then descends in the lateral funiculus to synapse on motor neurons or interneurons. Because most fibers cross at the medullary pyramids, this tract contains contralateral limb movement. The anterior ventral corticospinal tract, by contrast, does not decussate at the medulla. Instead, its fibers cross segmentally near the termination, predominantly influencing axial musculature. Beyond the corticospinal system, a network of extrapyramidal tracts modulate posture, reflexes, and involuntary motor patterns. The rubrospinal tract, originating in the red nucleus of the midbrain, descends contralaterally and assists in upper limb flexor facilitation, although it is less dominant in humans. The vestibulospinal tracts, both medial and lateral, arise from the vestibular nuclei and play vital roles in balance and posture, driving extensor tone and head righting reflexes in coordination with input from the inner ear. The reticulospinal tracts, originating from the pontine and medullary reticular formations, influence muscle tone, autonomic functions, and patterned movements. The pontine tracts tend to facilitate extensor tone, while the medullary tracts exert inhibitory effects. Another important pathway, the tectospinal tract, originates from the superior colliculus and coordinates reflexive head and neck movements in response to visual and auditory stimuli. Together, these descending tracts allow the brain to exert nuanced control over the spinal cord, integrating voluntary movement, postural adjustments, and reflexive responses into a fluid and coordinated movement or whole. They interact constantly with interneuronal networks and sensory pathways, creating a highly dynamic system capable of rapid adaptation. Ascending and descending pathways do not operate in isolation. Instead, they interact with the spinal gray matter, where sensory input converges and motor output is shaped through the same interneurons and inhibitory or excitatory circuits. Reflex arcs, locomotor patterns, and locomotor pattern generators and autonomic circuits all rely on the interplay between these tracts. And the organization of these systems explains why spinal cord lesions produce highly localizable patterns of sensory and motor deficit, and why somatotopic integrity within the white matter is essential for coordinated movement and sensation. Having discussed the white matter, we move now forward to discussing the gray matter. So the internal architecture of the spinal cord, the gray matter, is best understood through the framework of the Rex laminae, a cytoarchitectonic classification system introduced in the 1950s. Instead of describing the gray matter merely as dorsal, ventral, and lateral horns, the laminar model divides it into 10 distinct layers, each containing specific neuronal populations and supporting characteristic functions. These laminae extend throughout the spinal cord, but vary in prominence depending on the segmental level and functional demand. Embedded within or spanning these laminae are several named nuclei, which are clusters of neurons with shared functional roles that support sensory processing, motor control, and autonomic outflow. So laminae 1 through 6 are responsible for sensory processing in the dorsal horn. The dorsal horn, which receives primary afferent input from the dorsal roots, is divided into these different laminae. Lamina 1, also known as the marginal zone, receives input predominantly from finely myelinated A delta fibers and unmyelinated C fibers, carrying pain and temperature information. Neurons here give rise to projection fibers that ascend in the spinothalamic tract. Immediately below lies lamina 2, the well-known substantia gelatinosa, a translucent, densely packed region involved in pain modulation. It contains numerous interneurons and is a major site of action for descending inhibitory pathways, as well as endogenous opioids, which help regulate nociceptive transmission. Laminae 3 and 4 form the nucleus proprius, a large sensory nucleus responsible for processing touch, proprioceptive input, and integrating the early stages of sensory signal refinement. Neurons in the nucleus proprius form relay points for the spinothalamic and spinoreticulae tracts. Lamina 5 is a convergence zone. This is where both nociceptive and non-nociceptive inputs interact. Its neurons receive deep somatic and visceral afferents, making it important for referred pain phenomena. It sends projections to both the spinothalamic tract and the reticulospinal system. Lamina 6, most prominent in the cervical and lumbar enlargements, processes proprioceptive signals related to limb position. Here, afferent from muscle spindles and Golgi tendon organs converge before being relayed to descending motor pathways and cerebellar circuits. Moving on to lamina number 7, which is the intermediate zone or autonomic nuclei. It occupies the intermediate zone between dorsal and ventral horns and contains several important nuclei. The Clark's column, or nucleus dorsalis, from T1 to T2, is a major center for unconscious proprioception. Neurons from this nucleus form the dorsal spinocerebellar tract, projecting ipsilaterally to the cerebellum to support coordinated locomotion. Within the same lamina, the intermediolateral cell column present in T1 to L2 segments houses sympathetic preganglionic neurons. These neurons send axons through the ventral roots to synapse in the sympathetic chain or prevertebral ganglia, forming the basis of thoracolumbar sympathetic outflow. In sacral segments, a similar region of the sacral parasympathetic nucleus contains preganglionic neurons that contribute to pelvic organ control. Lamina 7 is therefore a major integrative center, blending sensory input, motor coordination, and autonomic regulation. Laminae 8 and 9 are responsible for motor control in the ventral horn. Lamina 8 contains interneurons influenced by descending motor pathways such as the reticulospinal and vestibulospinal tracts, modulating posture and axial muscle tone, while lamina 9 contains the alpha and gamma motor neurons that innervate skeletal muscles. These neurons are organized somatotopically. Medial motor pools supply axial and proximal muscles, while lateral motor pools supply more distal limb muscles. In the cervical and lumbar enlargements, this lamina expands substantially due to the density of motor units required for limb control. Motor nuclei within lamina 9 form discrete clusters that correlate with specific muscle groups, allowing for highly localized deficits when these neurons degenerate, as seen in motor neuron disease. Lamina X, or the central canal region, it's encircling the central canal, is where we would find it as demonstrated in the illustration there. It's a thin ring of neurons and commissural fibers involved in visceral afferent processing and intersegmental communication. This region contains interneurons that participate in bilateral reflex coordination and has a role in the regulation of pelvic viscera. It's the area most affected in conditions such as syringomyelia, in which cavitation disrupts decussating spinothalamic fibers, leading to the classic cape-like loss of pain and temperature. As mentioned a few times in this presentation, the spinal reflex, which is the spinal reflex arch, is of importance and is vital to understanding why it is that we regard the spine as a sort of almost autonomic structure. So when a reflex begins at the receptor, typically located in the skin, muscle, tendon, or joint, these receptors, such as muscle spindles, Golgi tendon organs, or nociceptors, transduce physical stimuli into electrical signals. The sensory information is carried towards the spinal cord via primary afferent neurons, whose cell bodies reside in the dorsal root ganglia. These pseudo-unipolar neurons transmit impulses rapidly along their peripheral and central processes, entering the spinal cord through the dorsal rootlets. Once inside the dorsal horn, the course of the reflex depends on its complexity. In the simplest form, the monosynaptic stretch reflex, where the afferent fiber synapses directly onto an alpha motor neuron in the ventral horn. This occurs in the classic knee jerk or patellar reflex, where muscle spindle stretch leads to instantaneous contraction of the same muscle. This direct linkage allows for a fast, precise correction of muscle length and tone, essential for posture and balance. More commonly, however, spinal reflexes are polysynaptic, meaning that afferent neurons synapses onto one or more interneurons within the spinal gray matter, primarily in the intermediate zone or lamina 7. These interneurons integrate, transform, or distribute incoming signals to multiple motor neurons. A prime example is the withdrawal reflex, in which a nociceptive input from a painful stimulus triggers a coordinated withdrawal of the limb. Here, excitatory interneurons activate flexor muscle motor neurons, while inhibitory interneurons simultaneously suppress extensor motor neurons, a mechanism known as reciprocal inhibition. This ensures that agonist and antagonist muscles do not contract at the same time. An important extension of this reflex is the crossed extensor reflex. When one limb withdraws, interneuronal circuits cross the midline of the spinal cord to activate extensor muscles in the opposite limb. This counterbalancing movement preserves posture and prevents fall, illustrating how even simple reflex circuits are integrated into whole body motor control. Motor output is carried by alpha motor neurons located in the ventral horn, whose axons will exit the spinal cord through the ventral roots and ultimately synapse on the target muscle. Gamma motor neurons simultaneously adjust muscle spindle sensitivity while allowing the reflex arc to function harmoniously during voluntary movement. This coordination ensures that changes in muscle length continue to be detected accurately, maintaining tone and preventing oscillation or destabilization. Although spinal reflexes operate independently of the brain, they are heavily modulated by supraspinal pathways, descending tracts, particularly the corticospinal, reticulospinal, and vestibulospinal systems, to adjust reflex threshold, strength, and timing. This modulation allows voluntary overrides of reflexes, refinement of muscle tone, and adaptation of reflex responses to situational demands. When these descending pathways are damaged, as in spinal cord injury, stroke, or upper motor neuron lesions, reflexes become hyperactive, leading to spasticity, clonus, and exaggerated tendon responses due to the loss of inhibitory control from the higher centers. Thus, the spinal reflex arc represents a dynamic balance between rapid, automatic circuitry housed entirely within the spinal gray matter, precisely tuned and modulated by descending influences. It is indispensable for protective responses, postural stability, locomotion, and the seamless integration of voluntary and involuntary movement Its neurological examination through tendon reflexes, muscle tone assessment, and evaluation of pathological reflexes remains one of the most important bedside tools for localizing and characterizing nerve system lesions. So that brings us to the end of my presentation, and we have a few key takeaways today. The first of which is that spinal cord is segmentally organized but anatomically shorter than the vertebral column. It ends at L1, L2 in adults and L3 in children. Lumbar and sacral roots afterwards descend as the cauda equina. Gray matter is regarded as the processing hub of the spinal cord, with the dorsal horn responsible for sensory processing and the ventral horn for motor output, while ascending tracts carry sensory information up to the brain and in terms of white matter, and descending tracts mediate voluntary and involuntary motor control. But by far, the biggest takeaway from today is that the spinal cord is not just a conduit, but rather it's a highly organized, autonomous processing center. These are my references. Thank you, everybody.